Macro perspective, peeps, what is going on? Continuation of our Cenegenics Guest Series. Marcus and I are super excited today to get Dr. Taylor Martin in the house. I am personally excited for this one because Dr. Martin and I have been working pretty close together for, I'd say, about 3 to 4 months now, right, Dr. Martin? And getting to see Dr. Martin work in the trenches, man, it has been amazing to get that. Dr. Martin is an amazing physician here at Cenegenics, and this is his background, and just to see him get to work with our patients, get the results they want, and the passion and the type of drive that he has to get the outcomes he wants for his patients, the passion is without a doubt, like you can feel it all across everything. So this is why I'm super excited to get him on the Cenegenics Guest Series, the continuation of it. But Dr. Martin, would you mind kind of doing like a deeper, brief overview of you from basically what got you into medicine? Like, what was the driving factor, the purpose, the why of like, I got to go to school for this? And then how did you get into where we're at now, longevity and, preventative care?
Yeah, well, thanks so much for having me on, guys. I love the podcast, and it has been great working with you, Seamus, at Cenegenics in Beverly Hills. We got quite a good clinic system going there.
Yeah.
So I'm originally from Arizona, and I've always wanted to be a physician. I want to really make a big impact on the quality of healthcare that's delivered to patients, since that's kind of been my mission from the get-go. And so I kind of went through undergrad and then went to medical school. And there's two types of physicians in the United States. You can either go to an MD school or a DO school, but then kind of the outcome is the exact same. You're still a physician. And traditionally, the DO schools have been more focused on teaching kind of the mind, body, spirit aspect that is lost in some of the allopathic medical schools as of late. And so kind of from the beginning, I was a little more interested in that kind of a practice, a little more comprehensive, and looking at some of the things outside of just pathology inside the body. And then I went to my medical school was in Chicago, and there I was working at a federally qualified health center. So it's basically an outpatient clinic for all the uninsured or the Medicare and Medicaid populations, and then working at the county hospital, which is kind of the one of the few remaining public hospitals in the United States. So seeing very, very poor patients in the outpatient setting and then the inpatient setting. And there were a lot of patients who I was managing on the outpatient side who I would see get admitted to the hospital and have these really expensive hospital stays. There was all sorts of issues that happened. They had to go up, they escalate to the ICU. They need these emergency surgeries, all because these chronic diseases were not being managed appropriately. And I was actively trying to manage those in the outpatient setting. And so that kind of really opened my mind to this kind of Band-Aid approach in modern medicine, where you're waiting for disease to walk in the door and then you're just treating that disease, as opposed to kind of finding the root cause of the issue and fixing that root cause. So that's how I learned about preventive medicine. I was able to do a rotation as a medical student and go in to Hopkins and do this rotation, and it really opened my mind. I had never heard about preventive medicine. A lot of medical students aren't aware of it as a smaller specialty in the United States. But then after medical school, I went to Hopkins to train in preventive medicine, and that's what my primary specialty is in. So preventive medicine is kind of like primary care, but the way that you approach disease is less about diagnosing and treating, and it's more about approaching disease through the three buckets of prevention, which is primary prevention, preventing disease from occurring in the first place; secondary prevention, identifying that disease when it does happen; and then tertiary prevention, once you've developed the disease, preventing that from causing end organ failure and death. And so that's where I kind of really found my stride in medicine. Up to that point, I was quite frustrated with that quality of care. I felt like I really wasn't doing anything that important or helpful to people. Maybe give an antibiotic here or there, but really we're not fixing diabetes or COPD or CHF. We're managing those. So I really like this approach of preventive medicine, and been doing that since. I came out to California a few years ago to work at the UCLA and train in clinical informatics, get kind of a second subspecialty training in clinical informatics. And that's like data stuff. I'd be happy to dive into that if you guys want to. And then from there, found Cenegenics and really liked what they were offering. I mean, I think all the problems with the traditional health system, Cenegenics is kind of solving in their own unique way. So yeah, I guess I'll stop there.
I love that.
Man,
First off, it's Powerful. I'm gonna let Marco speak here, but like the moment you said informatics and data, Marcos is like a light bulb went up. Ah!
I mean,
That's the money, man.
yeah, data, being able to access your health data, and then the fact that there's, I guess, perhaps the person that makes the app that has something that's integrative and I guess HIPAA compliant would probably make a killing in the modern world to be, because so many people are like, I had a blood work drawn with X physician and I can't get it for you right this second. But then if it was all in like one hub, and I don't know, your Apple Health, for example, if there was a way for it to port into there automatically or whatever that informatics looks like would be, I think, really clutch, because then more people are having these conversations if they are going to specialty care and things of that nature. And you really shed some light there about like that preventative model and those different instances. I know in my almost 6 years of being with the company that, so many people walk in with like a pre-diabetic kind of A1C and or even just glucose as a whole. And, I think it's over 50% of the people that walk through our doors that have that, and they had no clue, So are there ways to continue to get people to become more educated in a simple manner? And where do people start and from your expertise, what do you see? What do you think would be really helpful for somebody?
You're talking about some of the limitations with a traditional health system, but I still think that everything is based with a relationship with a primary care physician. They are I think of this hub and spoke kind of model where the primary care doctor is in the middle, and they're the one kind of helping you coordinate all your care, to your specialist, to your preventive medicine doctor, to your GI specialist. So I think going to a primary care doctor who is able to spend enough time with you and really address your concerns is going to be the best place. Now, I heard a at that time, because I think you're identifying the big issue there, is that a lot of primary care doctors, the way primary care is structured today is that they have 15 minutes to see you, and they can treat 1 to 3 things, and then you're out the door.
Yeah.
So finding someone who's going to really individualize care and have enough time to really spend with you and dive deep into past medical history and family history and labs, and if you have time, genetics and maybe some GI testing is going to be kind of the first approach there. But you had brought up an earlier point about informatics, and I think that highlights kind of the old way that healthcare was delivered and made this new emerging way that puts it more in the consumer's hands. And so I think there's other tests that you can do without having to rely on a primary care doctor to start to identify these things. And so traditionally, everything's been done through the health system. It's kind of this shining beacon, and the only way that you're going to get healthcare is you got to come to our place, and we'll give it to you only there. And you can't get it at home. You can't do these tests on your own. You got to come to our clinic, and we own all the healthcare data. And UCLA owns that, Seamus's healthcare data at UCLA, and then Cedars-Sinai owns his data at Cedars-Sinai, and it's all these different silos of medicine, which comes up with a huge amount of issues. Now it's starting to emerge that there's these personalized health records that you own your own data and you carry it wherever you go. If I go to emergency room at Cedars, I can show them my data, and they'll kind of re-upload my personal health record. And so that's a really powerful way of putting kind of the onus of the care in the hands of the patient, the one who's ultimately the most responsible for the outcomes of that. And then from that, there's been kind of new emerging ways of direct-to-consumer diagnosis, like diagnostics. So a lot of the wearables there's a bunch of diagnostic power inside of those. We're not even really utilizing those in the healthcare systems, but like sleep trackers and even just like the wearable, the heart rate monitors and stuff like that. I think patients can start to identify disease early on than they may be able to traditionally get in a healthcare system.
That's that onus of having that, like you just said, on yourself is like a unique thing. And like you said, that kind of hub and spoke thing, going back to that though, like 15 minutes. So then in your eyes, like what is the maximum number of patients that the system should limit a PCP to actually have? Do you feel like there's an actual upper limit threshold? Because again, to get in, you might take 3 to 6 months just to see a primary care to get like something established. And then the thing happens, right? Your insurance changes from your employer, and then you have to go establish new care with somebody else because it's no longer provided. And you no longer can afford them because they're out of network. Like how would there be something that's like a solution to like a cap, or is it really more about like what our model does, and you kind of have to pay out of pocket, and you have to kind of go with the premium, but you're actually going to be given care as a human being and not like a number in a system like you are like in colleges, for example?
Yeah, it's a great question. I think the most simplest way is doing it like we're doing at Cenegenics, where it's kind of a cash payment. It's a higher end service, and so the physicians are compensated well enough that they don't need to see 2,000 patients. They can see 200 patients and really manage those patients really well. And then they have lots of time to spend spending 2 or 3 hours with that patient in a single day, and calling them on a random day and having enough time to do that. Where when I was practicing at UCLA, I certainly did not have enough time to do that. So I think the most simplest way is kind of a cash system where the physicians or the practitioners carry a small patient panel. Now that being said, that starts to create kind of a tale of two worlds, where those who have get really good healthcare and those who don't get really poor healthcare, and it's that underserved group that's really driving healthcare costs up in the United States. So from a kind of policy perspective, I think it's kind of more important to open up these pathways of getting better care to lower income people. And there's very complex ways of doing that with combining payer systems and delivery systems. So like a hospital that owns their own insurance company, they're financially incentivized then to decrease the cost of care and be really proactive about this sort of thing. There's also models where there's case coordinators. And so while the primary care doctor still really only has 15, 20 minutes per patient, there's other kind of services. So if you're a high risk patient, you're kind of put in this registry and there's always a doctor checking up on you. Or if you're a diabetic patient, you have a nurse reaching out to you once a week to check how your diet is doing and see how your CGM data looks and stuff like that. So I think there's complicated ways that healthcare systems can kind of structure things to improve that model. But from the simple perspective, it does seem kind of moving outside of the traditional kind of health insurance, big hospital system model.
Sounds like you have to create it so that the institution doesn't go for profit and have shareholders effectively, right?
Well, that's a pretty good idea.
Yeah. I heard that in an episode somewhere recently. They're like, the best model that makes sense for healthcare is for the entity to be a nonprofit. And that way, like, again, people also need to understand what that actually means. Just because the organization is not for profit, it doesn't mean that the people that work there don't get paid and they, live a high quality life. They are able to do and deliver services at that higher level. And again, like you just said, if a physician really has a caseload of 250, 300 people that they really have like that buddy kind of relationship with, maybe they do have enough free time to go serve the underserved community and get them to have more of that preventative care. And, again, not have so much of a strain on the system where it's like, hey, your premiums for your family, because like your employer covers that cost, right, is $700 for you for your family, and that's like marginally just getting higher year after year after year, because the people that are going to the clinics that you worked at, right, where that's like Medicare, Medicaid, and all those things that are government funded, right, like there's probably some taxes or some other things going on behind the scenes we don't see or really know about that's helping subsidize that to some degree. It's definitely a strain on, well, typically the middle class America, which, I know I qualify for that. Shane, is that where you're at? Yeah, pretty much. Yeah, you're on mute.
Pretty much. Once you hit a certain threshold of cash, you report that into your person, and then they're like, yeah, good thing you got an LLC so we can write some things off. I was like, thank you, but it's like you make a certain amount. It's like, I feel like making a certain amount. I was like, I should just make
less,
more than this just to get out of this problem, or like make less. It's like one of the two problems. You know what I'm saying?
I think this tends to be a common issue in healthcare. There's this kind of this donut of people who are missed. Like the very poor people get access to a lot of subsidized care, and then people who have a lot of money can pay for all sorts of things like Cenegenics. And then it's that group in that middle, that kind of lower middle class group that gets left out. They don't make too little to get Medicaid, so they have to use commercial insurance, but it's so much out of their paycheck that it's exorbitant and they can't really afford it.
Yeah, man. It's like nine grand a year for me. Plus then I contribute an extra $400 a month into an HSA. So my all-in expenses just to have like my family covered on a $10,000 family deductible, which again doesn't really cover a couple owies or a dislocation and things at an ER, which is the current situation that I'm actually in, is paying for a service that was literally like 2 X-rays, with the machine that company likely owns, because I looked it up, it's like, oh, it's only $100,000. They probably paid for, like, based on what they charged me for the scan, they'd used it 100 times and they paid for it, right?
They already
And
paid for it like the first week, man.
I'm sure. I'm just saying, like, if you were to justify the actual expense of the cost, and I understand the technician and the people that are getting paid as well, right? Two different things, but I'm just like, I was dumbfounded that the actual visit prior to the insurance was like roughly 10,000. Then my out of pocket is 4, even though that's in network. I'm like, no wonder why. Like, I'm literally the statistic. Most people don't have enough leftover cash around, because I thought maybe a visit to the ER for a little elbow dislocation for my daughter would be, 1,500, not $4,000. Like, I'm like, okay, well, now I know. Now I'm trying to like build that nest egg up even more to be able to handle that. And that's me, the middle class ish person, whatever. I don't even know what I classify as, but it's crazy. And again, like, then you don't want to do what everybody else does and not pay it. Like, a lot of people will get that and they'll write it off. They'll wait till it goes to collections. They'll, not do anything with it. But I tend to have some morals and I want to be able to take care of it. And it was the first real instance. It took me 31 years, and how many years without my parents' insurance? 6. So it's like 6 being on my own plan, where I'm now dealing with something that I never had to deal with, and the healthcare system it's really changed. I feel like since my mom had cancer 20 years ago, where everything was covered, into nowadays where, again, just a normal person that even works in the system, in a system, not the system, with healthcare, again, what is it's basically 15 grand a year, you know what I mean, just to like have access.
Yeah.
It's insane. Yeah.
Yeah.
The whole funding system is a complete mess. Like you're describing, you are subsidizing the cost of everyone who isn't paying their share, which is why it costs $90 for a bag of saline, just salt water in the ED. So it's extremely exorbitant to kind of cover all this other nonsense that, this inefficient ways of capturing the actual costs. My dad just had a knee replacement. They billed him $100,000, but then said, "Oh, we'll take 10% of that." So it's like, why are you even billing, $100,000 in the first place, $100,000 in the first place? And that's how you really bankrupt people from a medical perspective. It's people who don't have insurance, who have to pay cash, that they're on the hook for that $100,000, and that nobody can recover from that.
No,
So it's a complete mess.
I think too, the other thing is, like, there's no transparency. Like, you go to a office in the modern system, and it's not like buying a car where you know what the price is. You know what I mean? They hit you with the bill afterwards. Like, you're like, I might have my daughter wait like till tomorrow morning where I can go to an urgent care versus tonight. It's not life threatening. She's gonna be in a little bit of pain, but $4,000 versus going to my urgent care, which would cost me probably $200 to get it set and be like, it's fine, is, again, why such the huge discrepancy? Why not the transparency up front? It's, again, most people like that are, I feel like all of us would look at that and be like, you know what? I'm going to go get a second opinion because I don't really know if I have $4,000 to part with. You wouldn't do it. You wouldn't sign up for that. It's like, you basically have to put it on layaway or on a loan. So it's kind of crazy. Depending on who you are, obviously.
Yeah, it is crazy. Yeah. What other industry and the service costs thousands of dollars do you not know the price up front? And then you don't even know the outcome. Like, maybe the outcome's not even going to be helpful to you, and you're still on the hook for all that money. But it's not a simple fix. I've tried to build some kind of tech solutions for the health systems to better kind of estimate the cost of the care, and it's a complete mess. It really depends on the exact payer that you have, the exact contract that you have with the payer, the exact contract that the payer has with the physician group, which could be different from each health system. It's all over the place. It's completely disorganized.
I can only imagine.
I take care of me and Desiree, and we go through like Covered California, right? And we go through Kaiser, and even that was a mess. And I've been with Kaiser forever, and my background in that is that my mom works Kaiser Member Services, and she's been like a director there and doing all those things. So like doing the paperwork, seeing all that, I get it. But I'm like, this is still so confusing. Like, there's so much options. You got this platinum, gold, bronze, HMO, like whatever, PPO, and then it's like, what do we do? Like, what covers what? And it's like, you have to be. My mom even said once, she's like, you kind of have to have almost like a degree in being a lawyer or like reading a lot of administrative nuance just to understand what you're reading when it comes into your annual Covered California. And I was like, yeah, it's just a lot.
Yeah, and we are healthcare literate people who understand the health systems, and it's still confusing for us. So think about somebody who's, maybe English isn't their first language, or they're less educated, or they're an older person. I mean, those people just get taken advantage of in the system. It's really important to have a healthcare advocate for you to really kind of help you move through a system in an efficient way. And some people that is a primary care doctor, and others it is not. Yeah.
Yeah.
So what you're basically saying is I should probably get a primary care physician now.
I think it's good to have a primary care physician. Now, that being said, I've started now telling my family, who's all middle class too, none of them are very wealthy, that you can get better care in a cash-based system
Yeah.
because you have more time with the physician. I mean, I don't know any health system that you can spend an hour talking with the doctor, but a lot of these cash-based systems, you're able to, and you can get much better, higher quality, quicker care in
Yeah.
this cash-based system for
Yeah.
like primary, like outpatient stuff.
Well, I like that.
Yeah.
I kind of want to talk about that then. Like, so like obviously with the Cenegenics model, like you kind of hit the nose on the head there. Like, I know you told me in a story once that you're like, yeah, it's like 15 minutes, and then you were like, but really it's like 7. when because you have to do like your soap notes or something afterwards. And then you're like, yeah, I really like the Cenegenics thing because I'm spending like 1 or 2 hours. Tell us about that. Like for the listeners here, like obviously without going too deep in like the whole IP, but like what does that look like, that relationship with you and your patient base of like, I get to spend this time with this person and I get to do all this. How does that look like?
Well, I mean, even just disregarding the patient outcomes, it's way more satisfying for me as a physician. I feel like I can really connect with a person and help them walk through different things, and they do kind of become a friend in some aspects. None of that I can get in a traditional health system. So I do think all physicians would have a better career balance if they considered an opportunity like this. But basically, it comes down to really diving deep into past medical history in ways more so than just, have you ever had diabetes? Have you ever had cancer? Really understanding what their family history is, learning about when their grandparents were diagnosed with dementia, and what risk factors their grandparents may have had, trying to better understand what the risk this patient specifically may have. Spending lots of time going through diagnostics. Seamus does a lot of diagnostic testing with the patients before they come to me. And so there's loads and loads of data for us to go through. And I'm a data nerd, so I like going through that stuff in detail and really diving as deep into it as the patient wants to. And this is really individualized medicine. I mean, it's, we are customizing our treatment plans based on, this 2 or 3 hour conversation that I've had, but then these other 1,000 data points that we've collected. And that's much more tailored to the physician rather than, oh, it's asthma, I'm running down this algorithm, therefore I'm going to give them albuterol inhaler. So it's very satisfying from a physician perspective. It's satisfying from a one-to-one kind of person connection perspective. And it achieves better patient outcomes as well.
Yeah.
I mean, it's funny you mentioned that because like now that I've been kind of doing some different, some helpful duties, just like with the paperwork and setting it up and doing that, like, again, also making it easier for people. So like, I know how everybody probably complains, damn, I feel like I already filled out this paperwork last year. Why I got to do it again? Like we go through that process for like our patients in the Las Vegas office to like make sure that like, it's like check a box. Does this look right? Yes or no? And like, okay, if no, that like, you know what I mean? Like on it. And same thing, like listing a lot of detail that's like very concise, so that like when Dr. Makhtari looks at what's been going on, like that patient at a glance, like that view that he has to kind of have like those master controls, he's like, okay, I already know about these things. I know I need to get him to like move into this additional like diagnostic and screening. We haven't done this yet. Definitely is, on board. Just want to make sure that we're, again, being preventive, even more preventative than preventative really maybe even needs, just to be certain, because everybody is not the same, even if their labs look good or something like that. So it's I like you saying that like really hit the nose on, really hit that, like hit a chord, struck a chord with me. Like, oh yeah, like now I see why he's making us be meticulous and have this right here so that we can all see it. We're all aware on staff to make sure that these people are being taken care of at a very, very high level. So
yeah, and that's what you need, is a team-based approach where everyone is on the same page and everyone is providing good insights to the patient. Seamus and I will sometimes, tag team our patient encounters, and Seamus is always throwing in stuff that, I'm missing, or, I wouldn't necessarily, bring to the forefront. And that's because Seamus has done a really good job at understanding what exactly is going on in the patient and their goals, and trying to come up with a treatment plan himself. And I feel like that's another unique thing about Cenegenics, is that we work really closely with these other healthcare professionals. Wherein, at UCLA or other health systems, I'm not trying to pick on them. That's just kind of where my examples are.
Yeah.
Everything's so siloed. Like, in order for them to speak to a nutritionist, I have to send a referral, and they have to go somewhere else, physically somewhere else. I'm never speaking to that nutritionist. Maybe I'll send them a message, but we're never on the same page. We're never even looking at the same data, like how you just described, at the patient at a glance.
Yeah.
Yeah.
No, that
Yeah.
makes a lot of sense because I've had that before, like just outside of Cenegenics, just like just being like from a personal training standpoint, like when we're personal training, like you'll get people that are like, oh, my doctor told me to do this. These were his notes, and then this nutritionist told me to do that, and it's like I'm coming here, and it's like I have to download on so much, and then it's still wrong. Like the approach I'm giving is probably still wrong. Or why would your doctor say this but not this? Or why would your nutrition say this but you're getting these outcomes? And it's like there's so much disconnectedness that it just doesn't allow for a cohesive approach. And I feel like that makes the patient frustrated because they're like, well, I've gone to this guy, I've gone to this guy, I've gone to this guy, I've gone to this person, I've gone to this person, and it's like nothing is working, And like they want to work, it's just they're kind of misled.
Yeah, it's incredibly frustrating, and then it totally undermines their trust in any of the healthcare professionals. They say one cardiologist said this, the other one said this. Obviously, they're thinking different things. Maybe I shouldn't even go to a cardiologist. Maybe I'm just going to learn about lipids on YouTube from, I won't say any names, but
we have no. You can say it. You can say it. We're small enough to where we can say what we want.
Okay, all right. Some Paul Saladino type people.
There you go.
It leads people away. There's a lot of mistrust and anger with the health systems for good
Yeah.
reason. But the problem is that manifests in getting that same, just believing a prophet who doesn't know as much as the specialists do. And so there needs to be a better way of communicating those things, and all being on the same team page to build trust in the overall system. Yeah.
Yeah.
You know what? I want to hit the nail on the head on this for a little bit. I want to extend this a little bit here, if that's cool with you, Dr. Martin. We talk about this a lot. We're here on the pod. You're obviously a public-facing face. You're dealing with Cenegenics. People that come into Cenegenics, obviously, they probably heard from it from a podcast, or heard from it from somewhere else, or heard from it, and these people are taking in information. How have you felt information has been because of social media? How has it taken a hit on like your day to day with people? Because these people are smart, so they're probably taking the information. They're probably trying to solve these things on their own. They go down a rabbit hole, like maybe they do the Paul Saladino thing, and then there might be people that aren't necessarily as educated, but they heard the thing that Paul Saladino said or someone said, and they're like, well, that's what he said. So there's this mistrust. Like, how have you seen that play out in your work life?
I would say, I mean, I'm still a fairly new physician, so I don't know what it was like, pre internet era. I would say the influx of disinformation, the ratio is probably the exact same of disinformation to information as there was pre and post internet. I think it just made that a lot more accessible. I don't think there's
Yeah.
necessarily more, because there's a lot of good information still online. I mean, really, you could, to study for the board exams, become a physician, all that stuff is public online. So technically, all the information to become a doctor is online. There's also just a lot of bad information on there. Now, when it comes to patients, I actually really like when they have done their own research and they have some topics and they want to bring them up to me. And I like talking through all these things, and, not necessarily debunking, but, discussing my opinion and how I see the research, and maybe pointing out some logical flaws in some of their arguments. And, most people who are coming to me and bringing these things up, they want to know my opinion. And so, they'll give me a little bit of pushback, but ultimately, I don't know how much of it is convincing versus them just being open-minded, but we can usually come to the same page. What I fear is the people who listen to those podcasts and then just assume that that's the truth and don't ever go in and see a doctor, or don't ever discuss this with their doctor, or they're too scared to bring it up to their doctor. And so they just kind of keep it on the hush hush. And the doctor prescribes them a statin, and then they just never take it. And the doctor thinks they're on the statin for all these years, and they're just never on it. So that's the group that I think is being most harmed by the disinformation is, the group who doesn't have kind of a trusted medical source that they can bounce things off of. But overall, I really like it when patients are watching podcasts or sending me papers and even just sending me portal messages and want to chat about, something like that. I like those conversations.
Okay, question though. What's the most heinous thing you've seen on on social media that you're like, that's some BS, man? Like off the bat, you're like, this is dumb.
I don't know. There's a lot. What would be a good one? I mean, the whole carnivore thing, just off the top of my head, is jumping out in its relation to heart disease. Now, at Hopkins, we did some really extreme elimination diets, and the most extreme one that we would do is put people on just beef for a few weeks. But that was we weren't at all promising that this is okay for heart health. This was to treat a specific GI issue or inflammatory issue, and then we kind of layer things back on. So there is some truth kind of buried in that whole kind of carnivore argument. And not everyone is going to be harmed from a carnivore diet, but largely, I think a lot of people are. Actually, let me refine that. The lean mass hyperresponder is, I think, the thing that really jumps out to me, because everyone assumes that they are a lean mass hyperresponder, even though very small amount of the population is.
Like
I don't know if you want to explain what that is, but
maybe like 1 to 3%. Like that's the outlier.
Well, explain lean mass hyperresponder, assuming this person is like a 5-year-old. What would that actually? What do those words mean? Out of curiosity.
So a lean mass hyperresponder is this phenotype of person that we're just starting to learn about. And they've done some really interesting studies here at UCLA, and they are kind of in the process of publishing them now about it. But I guess taking a step back, our kind of modern hypothesis on how you develop plaque in your arteries, which then ultimately causes heart attacks and strokes, is that by having large amounts of ApoB particles, so LDL, VLDL, Lp(a), all lipoproteins that carry atherosclerotic risk, by having those high, they deposit plaques and then increase your risk of heart attacks and strokes. Now, there's we don't know the size, but I'm assuming a very small subset of people who can have really sky-high lipids, so ApoB containing lipoproteins, and they do not deposit any plaque. And so they've done these studies where these people, they tend to be leaner, so that's where you get the lean from. So in a BMI from, I think it's 22 to 27 or something like that, they're often on keto diet. Their LDL's like in the 300s, 400s, and they'll do CCTAs, and they do not develop plaque. And so it's a really interesting subset of people that we need to do further research on. But because this has been starting to get published, and these influencers have just exploded this and saying, there's data that the LDL does not lead to plaque, a lot of people then just assume they are this phenotype of person. And so I think it's I guess it's a dangerous example on some of this misinformation.
It's also a little different than what I expected. Yeah, it's also a little different than what I expected it to mean. So you clarifying that is actually like really helpful, because it's definitely in terms of like lipidemiology, essentially this person that does have this phenotype of being lean and having a good amount of lean mass, but also you said a BMI that technically bridges two spaces, like being healthy weight and overweight, technically, if we're saying it's 22 to 27.
Yeah. I mean, I think that brings in, some of the issues with BMI, using BMI as any sort of individual metric.
Perfect.
Yeah.
It's just, there's height to weight rate, or height to weight, ratio, right? But at the same time, you said it could potentially be 1 to 3% of the population. I mean, that could be, 3 to 9 million people in the U.S. population, if that is deemed to be true, if that's the representative, correlation, right? And I think that's the other thing too, like causation and correlation are two very different things, right? Like, these potential thresholds of numbers, I don't know. This is where I start questioning a lot of things. One, familial history. I have a theory about that, like environment. It's maybe more environmental than actually familial, because families tended to live in pockets of the U.S., right? If we're using the U.S. as like our sample size, and their environment, like the water they're drinking, the foods that they're getting, the produce, the animals, all those things likely played maybe more of a role in their potential, health outcomes, right? Versus I wonder if it changes in the next 100 years as more people get away from their home after, adolescence and their teenage years, right? How much does family history still play a role if you're not living in the same area? That's one thing I've questioned a little bit. But the other thing too is, with God, where was I going with this? With all these things and all these different data sets, and like, again, people not maybe understanding causation and correlation, right? Like, yes, like these things are very individualized, right? And like you'd mentioned, looking at somebody's like CTA after they potentially have these higher markers. There's where the question is, like, do you still go on a statin if you have like a clean calcium score and you're running at like 240, 250 for your total, and your LDL is high, but your HDL is at like 80? Out of curiosity, what do you do there?
Yeah, it depends, and that's why it's really individualized. Let me think how I would, that kind of depends, on the person's risk, kind of other risk factors. Do they have other things that put them at risk for heart attacks and strokes that may be outside of the lipids, like hypertension, or hemochromatosis or something like that? A family history plays a role in there. Also just kind of how old they are. Is cognition already an issue? Because sometimes that can be an issue with the statins. Are they already diabetic? Or do I already have elevated LFTs? Both those can be side effects of the statins too. So just because someone has a negative calcium score on a screening exam doesn't necessarily mean that I won't ever prescribe them the medication, but it definitely certainly lowers my how aggressive I want to be. But you bring up a great point. 1 to 2, and sorry, let me clarify. If I said 1 to 3%, those aren't real numbers. Okay.
Those
Gotcha.
are me.
Okay.
That was me.
Okay. That was you.
We were saying like a certain amount of population, which most like outliers are like within like.
I was just giving numbers for context. Yeah. Like, like the numbers can blow up really largely, and they think they're a bigger part of that population because that number looks large.
Yeah. Well, I mean, that's a great point. Even if it's 1%, that's 30 million people in the United States. That's a really good reminder to me to be humble when I'm talking about lipids and not say high ApoB will cause a heart attack and stroke, because now there's objective proof that it won't in this subset of population, and maybe there's other subsets like that, and maybe that number is bigger than what we think right now. So I think it all is really nuanced. It all is weighing the pros and the cons of certain medications, and then thinking about sensitivity and specificity of the testing too. I mean, we talked about the CCTA. I guess redirect me if you guys don't want to dive deep into this, but there's different ways of testing if you have plaque, and they all have errors, and none of them are 100% sensitive. And so even being a 0 on a CCTA does not necessarily mean you don't have any plaque.
Mm-hmm. You know what? I feel like that's a good topic for today, actually, is talking maybe a bit about that. Ironically, I'm considering going on a blood pressure medication because I've had a mildly high chronic issue with my systolic number. And I'm like, should I take something at 31 years old to be preventative? Like, I mean, I'm thinking like 40, 50 years down the line. I've never seen this number out of the 120s. Like, it's always just a little bit outside of that bound of like what we've deemed as like really exceptional. And I do everything I possibly can. Eat clean, train often, try to get as much sleep as I possibly can. Maybe there's too much caffeine, but who doesn't like to enjoy a little bit of coffee from time to time? But I'm like, is this a potential risk? So, I mean, understanding like atherosclerotic risk, I mean, it's kind of become a little bit of like a fascination point for me. So I think we can dive into it a little bit more. And you're specifically talking about like the clearly at this point, right? Because you're saying CCTA, right? And
yeah, exactly. So there's kind of some different testing options to look at calcium plaque. Kind of the most basic and the least invasive and the cheapest is the coronary artery calcium score. And so this is just a low dose CT scan of your chest. All it's looking at is for calcified plaques. So there's a few different types of plaques that you can have. There's calcified plaques. Those tend to actually be the least risky plaques. There's soft plaques, which are the most risky. Those can detach and go down the arteries and cause a block. And then there's kind of plaque outside the lumen of the artery, kind of on the outside of the arterial wall. And so the CAC just looks for calcified plaque. kind of
Okay.
step-up exam is a CCTA. It's an angiogram where they're spraying dye in your veins and actually looking at the lumen diameter and seeing if there's plaque. This can pick up soft plaque and hard plaque, but it doesn't pick up the outside of the artery. And so it's just looking at the lumen. But you can imagine if there's a really thick pipe, you wouldn't be able to see how thick that pipe is by just looking at how the diameter of the fluid going through the pipe. And then there's this really cool, so the CCTA is generally read by a cardiologist who is kind of visually going in and measuring the size of those plaques. And then there's this new offering called the Clearly that uses AI to identify these tiny, tiny plaques that can't be seen by the human eye. And so this is a really great exam, really great test for looking at soft and hard plaques. And we're starting to offer this at Cenegenics, and I think it's a great way of really understanding your risk of cardiovascular disease. And, if you are a borderline, most specifically lipids, but even kind of what you're describing, Marco, with a kind of borderline high blood pressure, I'd be thinking about decreasing my risk of cardiovascular disease. And should I start a statin or should I start a calcium channel blocker? This may be kind of the good decision pathway to understand, should I go ahead and do that or should I hold off? And then just to point out one more, then there's I just know it as IVUS. It's, I don't know what the IV stands for, but it's an ultrasound basically of the arterial wall. And that can pick up both in and out. This is a really invasive test. Really only cardiologists do it. But that's really kind of the gold standard of identifying plaque.
IVUS. I see. Yeah, I learned it is something today. I feel smarter from you giving me this. So you're saying that one actually gives you the potential thickness of that arterial wall then with that ultrasound?
Yeah,
right?
yeah, exactly.
Okay.
And plaque kind of through the arterial wall and on the outside.
Okay, gotcha. Well, I mean,
the silver bullet, huh? It's like that.
but he said it was invasive, so it's not
invasive.
really easy to do.
Yeah, it's invasive. It's expensive. Not many cardiologists will do it. It's not ideal for right now. And so I think it's totally reasonable for somebody to start with a CAC. I think younger patients, if they don't have a strong family history, if there's a low pretest probability of atherosclerosis, then a CAC is fine. And some of these tests are helpful more than just at one point in time. Kind of trending these every decade of life, or trending these after a certain therapy. Like maybe you have some plaque on CAC, you start a statin, and you want to see if you calcify some of those plaques, which makes it less risky. You would do another repeat exam, and so you wouldn't want to stack a lot of these really invasive exams on top of each other. If someone didn't really need it. So it's kind of a balance between all of those. That's why I think getting with a physician who's comfortable discussing all these things, who really understands you and your priorities, is going to help with finding the most individualized choice for you.
I mean, that alone is worth its weight in gold. In this conversation, if people get that out of it, understanding those things, kind of even where to start, why to consider doing these things, what to look at. It's all feels probably overwhelming to people that are listening at times. And that's where, like you just said, really developing that care and, that rapport with somebody in a team of people that are supposed to be helping you every step of the way. Again, like you'd mentioned, the methodology you chose to go after wasn't the, quote unquote classical medicine route, right? Because you went DO, right? Versus just MD, right? So you wanted to have multiple channels or ideas that can help pinpoint what to help that person, which I agree. I think it's a blend of East meets West, right? Like there's probably things that, the Eastern medicine has done for millennia, right? Or centuries or however long it is, right? That have some merit. And then, wasn't it them that found out red yeast rice and then we've turned that into modern statins? Isn't that where it was derived from effectively?
I don't know if that's how we derive statins, but red yeast rice is pravastatin. It literally is the exact same chemical. Okay. Yeah, I think there's all this downplaying of Eastern medicine, saying it's not evidence-based. I think this focus on evidence-based things is really limiting our aspect to tap into different great pieces of medicine. Like you said, they've been doing this for a millennia. I would consider doing something for thousands of years to, millions of patients. Pretty good evidence that something either works or does not work. And we just don't consider that in our kind of as evidence or literature right now. But it really is testing a hypothesis and seeing if you get the outcome that you want.
Yeah, I wonder what they were looking at though. They're like, we want to live to see
the
next century, and or they just stumble. Again, these things are more silent killers, right? So why were they so interested, or how did they figure that out? Like, does anybody ever wonder about that? Like, why these things had gained so much popularity? What was it treating at that time? I don't know. It's like kind of eerie to think about, right? Like,
Yeah, that is really interesting. I mean, one
yeah.
hypothesis is that, for men, one of the first you're right, it is the silent killer. The most common first side effect is a heart attack, for cardiovascular disease. But the most non-lethal symptom is erectile dysfunction. And so maybe they were trying to treat that with it. I don't know.
They're
But
like,
there
oh,
is a
guess
lot of
what?
social drivers to treating that issue.
Yeah, no, that's
That's
funny. I mean, that'll drive anybody. It's like, yo, something's not working today. We got to figure this out, doc.
I think
Yeah.
that was part of our sales pitch back like 2 decades ago, was, live the younger you know what I mean? I think there was something in there regarding the implied libido enhancing of the treatment plans, but now it's evolved quite a bit more beyond that. Obviously, as we are now talking about things that are, again, like you said, it's downstream. Like, of course, if like you're having a metabolic issue, chances are you're probably not getting blood flow to the right areas, right? So, yeah, that's it's
I
funny you
want to talk about
made
this just for
that.
like a split second, Dr. Mark, because I think we had an interesting case study recently, but without going too deep into it, but yeah, ED, like this whole thing around it lately, right?
Mm.
Like, have you seen like an increase of that just in the, with younger men or anything like that, or just kind of an idea of just, you know, case by case basis, or like what's I just feel, because I work outside of Cenegenics as well, and I kind of just see like these kind of trends coming up social media, dopamine and everything, like dopamine just being spammed as a button, and yeah, like is there cases of ED just like going up in younger males and stuff like that?
I don't know enough about the population numbers to speak on that. I would say there's a shocking amount of young men with ED. And most of the time for men under 40, the most common cause of erectile dysfunction is psychogenic. It's nothing pathologically wrong with you. The plumbing, everything works okay. It's in the mind, or it's in the behaviors. I would say, yeah, there are a striking amount of younger men who are having ED. Um, yeah, I know you came up with some good ideas on this case that we were kind of managing together, and we identified some maybe lifestyle causes of the ED. And so that was a great kind of clue that you jumped down, and kind of a pathway we chased, and possibly found a solution for. Yeah,
Yeah,
what are your thoughts
yeah.
on it?
No, my thoughts on it are just like it's kind of that whole thing. I think in the manosphere, people talk about certain things, and it's just COVID hit, people at home, loneliness at an all time high, instant gratification at your phone, just people spamming that dopamine button through a sexual release of some sort. And it's kind of like this interesting thing, and not trying to corner anything there, but it was quite interesting what you did say though, which is like a good question that had come up is like, what is a good amount of for a male, like amount of orgasms in like a month or something like that, like uh you know you want to have good orgasms with a partner, not and have that
Mm.
oxytocin, and not have that what is it, I think JK said this, Marcos, right?
Are you
Prolactinemia.
making this patient write a log like he would blood pressure out of curiosity?
No, dude, no.
Oh, okay. I was just like,
No,
Yeah,
but like,
but you gotta
timing.
tally, it for me and make sure you're not getting too much oxytocin.
he's like, how much? What am I shooting for here, Doc? 20, 30?
These numbers are too low. Got to get these up.
These are rookie numbers. No, but I like that, because it's a concern, right? Because it's like, we kind of like Marcus was saying, it's like I think these are like some downstream effects, and it's like when you think about where male health has been, right? Like if we're trying to optimize male health, and there's this like governing thing that's stopping it. It's like everything looks good, labs look good, you're training hard, you're doing everything. Why are you not changing? Oh, just spamming this button. But yeah, no, it's a yeah.
Yeah, I mean, the online pornography is terrible for our brains. So we're not created to see those images at that quantity and that ease. So yeah, it's a quite negative, especially for a growing brain, like a teenager. Until they're developed, it's a quite negative thing.
Yeah.
And then, yeah, he asked us a fun question about, how many orgasms he should be having. And, there's mixed evidence about those things. So it's fun to kind of talk through those and, the pros and cons of different things.
Well, no,
Yeah.
I can appreciate the conversation just because, like, I know it's kind of a little awkward, a little like, but it talking with a primary care physician about your sexual health and having free reign to talk about sexual health, I don't think that's talked up enough. You actually, one of our performance health coaches worked with someone before. There's a company called Rosie where they talk about women's sexual health and like how sex, they these are things that like change with time with a woman. Like maybe at certain
Especially after
times,
kids. Yeah.
yeah, they're talking about like, oh, hey, like I was having sex, it was easier, and then at some point it started hurting. Like what happened? Or I'm dry, and it's like these things are probably not talked about, especially like you said with the primary care physician in 15 minutes. Like you're like, yeah, you can't even probably talk about it.
Yeah. Yeah. When you have diabetes and CHF and, you need a refill on your medication and you need a referral to the PT, the sexual health stuff is going to get buried at the bottom always. But it's super, super important for people. It can provide a lot of dissatisfaction. It can provide a lot of frustration. It can lead to some depression. It can hurt families or kind of cause rifts in relationships. I think it's a really important part of health.
Yeah.
Yeah.
Remember, guys,
I feel,
that's part of deep health. Like that sexual health is like a whole thing. Like, yeah.
well, yeah, I mean, I feel like that's like being a big chief complaint and a big number one listing reason, I know it's on our questionnaire is to like make sure that that's operating at what people would, again, like you're in your 20s or when you're in your teens or however you would view that as your like optimized version of that thing. Because I mean, yeah, you guys had an interesting case. I don't know if I've had quite that experience and had to dive into the weeds like
We
that,
need to
but I
put lacquer
definitely,
on our labs.
Yeah, I don't know if we need it for everyone, but it's definitely a helpful tool of understanding kind of the hypogonadal pituitary axis.
Yeah, yeah.
yeah.
Well, Dr. Martin, I want to be obviously super respectful of your time here. We're coming up kind of close to this hour. Let's kind of turn this around here a little bit. Healthcare, precision medicine, concierge medicine, longevity, all this stuff. With your background, the onset of AI, where do you kind of see this field going in the next 5 years? And I kind of preface this because in the last 3 to 5 years, especially with COVID tech, and apparently like healthcare are the biggest booms right now. So where do you see kind of like the space?
I think kind of these new emerging data sources that we've talked about, wearables, the Clearly, the Prenuvo, the direct-to-consumer MRI, full-body MRI, these sort of non-traditional healthcare data things that are directly marketed to the consumer, I think is going to keep getting bigger. Now, I don't think that's necessarily a good thing. I think there's a lot of harms that come from increased access to data to somebody who doesn't really know how to interpret it or how to act
Mm,
on it. So I think
Yeah.
there's going to be continued more companies growing. Then I think there's going to be a consolidation of those companies and a time where there's a lot of investigation into, does this actually improve somebody's health? Does this actually increase how long they live? And if not, then get rid of it. Then it's not providing
mm,
any value. So I think there's going to be, I think we're not quite at the full tree part, but soon
yeah,
we are going to get to that full tree, and then we're going to start pruning down.
yeah. No, I
Yeah,
think you're right because, like, I know we're working on something. You and I, we have a project talking about utilizing data collection through wearables. Like, just recently, I think Marcos knows a little bit more about this. I think he was reading it, but like, Apple was doing some certain integrations, Whoop, and then there's these new things from Samsung. Like, Aura Ring was killing it for sleep ring, and then now there's like this other ring, and this other ring, and this other ring. So it just, yeah, it seems like a lot of companies are primarily coming out with that. The data, it looks like it's primarily like around sleep and heart rate right now. I feel like they're and HRV, right? Primarily, right?
yeah. I mean, I think those have been the easy things to capture at this time. I think the last 2 or 3 years have shown that there's a huge market for people seeing their own data. People want the continuous glucose monitor. They want the Oura ring. They want to know
That's right. Yeah.
their sleep data. And so I think companies now are realizing the market, and I think this is going to keep expanding. I think a lot more continuous blood monitoring systems are going to develop. I think insulin is, I know people are talking about having a continuous insulin monitor. I know people are talking about having a continuous hormone monitor, is particularly for women to
Like
kind of better
cortisol?
understand
Yeah.
cortisol, but even estrogen and progesterone, to understand how those fluctuate in your body throughout your cycle.
Ooh.
So I think there's kind of a whole load of things we could be getting from this. And I mean, I think we're still kind of narrowly focused on things that make sense directly linked to healthcare. But you brought up this idea of AI and deep learning, and I able to identify trends and associations and non-traditional things. So pulling in data from where you shop or your social media or how often you're looking at your phone. I mean, I think all these things are going to kind of come together in these models that can help people kind of track their care and diagnose things really early.
I think that's one thing we've learned from Meta and Facebook over the years now, that the number one thing that people are able to sell in the modern era is your data. And that is something that, again, I didn't understand why people were so like up in arms about like data privatization and really having it private to you yourself. But now I realize, as soon as they know you and some of your tendencies and how many times you got to get fed an ad before you'll buy a thing or whatever that might look like that is some powerful stuff. It's insane.
Yeah, it's the new gold or the new oil or however you want to describe it. Data is the new resource.
It's energy, and that's I mean, everything in this world is an energy exchange, right? Whatever you value something at, is literally just that. And I think, the project that you guys are working on, looking at those things and wearable stuff, like, to me, it's funny because I love data. Like, my degree's in math. I don't know if you knew that, Dr. Martin, but so like I'm a math nerd. I like these things. I mean, numbers make sense, but as a practitioner, it only makes sense if people are actually going to change something because they are monitoring that data. You know, like, why do I need a continuous insulin model if I'm not going to actually change the food that I'm putting in my body? It's like, oh, cool, a crumble cookie. If I eat a quarter of it, like I get this much of a spike. And I had a buddy that he was wearing a Whoop for like 2 years, and he's like, I really need to work on my sleep. My Whoop tells me it's sucking. I'm like, so why not change the temperature of your house? Why not like do something about it, dude? And he's a smart guy. And I'll call him out. Zach, bro, come on. All those years of you looking at that data and you didn't change your sleep habits, like, come on. So
come on, Zach.
To me, and if you knew Zach's like an ex-CrossFit Games athlete, ex-Navy SEAL. So like, I'm like, dude, you know how to do disciplined things. Why aren't you just like putting your air down, like, or considering something like that?
Yeah, and maybe it's causing more anxiety, or it's obviously not causing any benefit, and maybe it's causing some harm, some anxiety or stress, or drawing his attention away from more important things like exercising.
No, he would come to the gym with me and he'd be like, I didn't sleep last night. I got like a shitty recovery score. What do I do? I'm like, okay. Like, does that really like play a bearing? He's like, well, I already know the workout's going to be bad because the numbers tell me so. So like, I'm like,
prophecy, dude.
Self-fulfilling. It's just like
Dr.
weighing yourself.
Andy Galpin and Brian McKenzie were talking about in that book Unplugged. Like, I feel like that book came out like 2017 or 2015, and they were already talking about all these wearables being like, all right, guys, we have all these wearables in the performance space. It doesn't mean anything, if you just like, if you're not going to act on it, is exactly what you're saying. Like, or, because I was using like velocity-based trainers with D1 athletes as a way to kind of see like their neurofeedback of like how ready they were, or like a grip strength. And it's like, yeah, the grip strength says they're bad, but the guy feels good. I'm going to go with what the guy feels today. You know what I'm saying? Like, sometimes there's a bit of, it's that nuance. It's that, well, how do we say it? There's the science and then there's the art, right, Dr. Martin? Like, being like the art, the coach, the guide on the side, like being in the primary care physician and being like, yeah, the science says this, but if we can work on these lifestyle things, like, yeah.
Yeah, that's a great point. I'm curious from your guys' perspective, like what are the wearables in the next 5 to 10 years that are really going to take off? Because it does seem like it is really focused on training and nutrition. It does seem like you guys are going to have kind of the ear to the ground in that way.
Ooh, that's a good question. I mean, if Whoop would give me a pedometer, I'd probably buy it. So sometimes there's basic things that are overlooked because of the other. We don't believe in steps being something we need to track. So Amazon had theirs. I thought Amazon was going to blow up, and they got rid of that department altogether, which was weird. I thought, and they had like Amazon Halo was what it was called. I mean, what's worth tracking? To me. Yeah, I guess if you can move the strap and you can kind of use it as a velocity-based trainer as well, because it can pick that up for like certain movements. I think from sports performance would be pretty cool. I feel like that's an easy thing with an accelerometer. Ironically, we have a patient that actually like told me he built an accelerometer that's the size of like a grain of sand that you can't see or a speck of dust. He's like, we can make them so small, but they can't go into like an actual like breadboard. He's like super smart guy. Actually a Cenegenics patient. I know he'd be cool to interview because he talks about like how he built that, as like part of his project. To me, like nothing else is really worth I guess like if there was a way to kind of like, what if you just constantly had all those numbers that are on our biomarkers, for example, all be done because it has that same sensor that a CGM does do. I mean, then you can start really analyzing things more of how that trends through time, because all we have ever really looked at is a snapshot. So I think the more things that actually allow for trend utilization would probably be where we get like even more granular with how we approach medicine. That would be something I think would be really cool.
Yeah.
I'd pay for that.
Yeah. Honestly, the quantified self movement got so deep, Dr. Mine had to step out of it because people were talking about like, oh yeah, track how many times I use the restroom or do this, and I'm just like, I don't know if this is, I don't know if this is the right like all that, but like just for being so like optimized. But I mean, like the basics, obviously, like I mean, I know HRV. They talk about HRV, but the HRV on the Whoop and all that it's like an RFSDB. It's not like a true HRV. I think that's why like Morpheus is probably the best, right, Marcos? Or like having a strap around the chest for true HRV. If you could have a constant HRV monitoring just to understand allostatic load. That's one of my favorites. The basics like steps, sleep. Temperature might be an interesting one. Just because,
would be interesting.
Because of the fact that like I know Marcos and I went deep into this about like sleep, and then also like if you're trying to conceive. I don't know.
Yeah,
it's really
the newest Apple Watch actually does temperature already.
Oh shit! Okay, cool.
Yeah,
there you go.
and ovulation cycles based off of that as well. It's actually like the selling point of like my wife was going to get the SE versus the 9, and I was like, well, if you get the 9, like you're actually looking at things. Not that we're getting pregnant again. We're actually done with that. I got snipped, But like it's just good to know because there are instances of like how her how she's affected psychologically around different periods of her cycle still, and like how her weight is responding as a result of that. And granted, the Flow app does a good job of like estimating that, but I guess you can get a little bit more precise. Hell, if you're just around your spouse long enough, you kind of tend to know like how they're feeling and what they're doing. I'm not meaning it from like a moody perspective, but just like certain like the conversation is different. And the tone, and then like how she's like her self-talk is a little bit different. But I think, you pinpointing that's pretty cool. But I don't know. I mean, like just when you think you might know enough, like hell, the people that came up with HRV initially was Sleep Number Bed, technically, right? Like they're the ones that like based off of like the breathing pattern of individuals, they were able to start analyzing things and get heart rates like based off of breaths. So like it's probably beyond what we can actually envision and imagine.
Yeah, it's
That's
probably
a good point, yeah.
probably the deal. All right, well, Dr. Martin, just kind of closing Cenegenics and kind of what are you excited for over the next, however long with Cenegenics? We'll just kind of close off on that.
Well, I'm excited about building the practice that we have at Beverly Hills. I've only been there now 4 months, and we're ramping things up. So excited to keep building that and working with you, Seamus, and the rest of the team we have there. Excited to bring in some of the new partnerships that we've been discussing. Maybe I won't call those out in case you guys have special things for them, but there's some exciting new diagnostics and kind of care delivery methods that we are deploying at Cenegenics. And so I'm really stoked to be involved with that and maybe some early stage studies evaluating the outcomes of those. And then, I mean, Cenegenics has, going back to this data topic, Cenegenics has been in this part of medicine for a very, very long time. And so that's one of the things that drew me to Cenegenics is that Cenegenics is a treasure trove of data, and there's a lot of cool stuff that we can start publishing, publishing about this, identifying specific kind of treatment outcomes based on our patient population. So it's more generalizable to kind of our next patient that comes in the door. So I think this is super powerful, both for all of society and all of medicine. I think they can learn a lot from our data, but also how we practice inside Cenegenics. So I'm really excited to start diving into some of that. I think Rudy, I listened to your podcast with Rudy, and I don't know if he exactly hit on that point, but he had also kind of brought up that you guys have tons of data and some kind of post hoc analysis is in the works.
Well, we got some deep work we're going to need to do for sure.
Yeah, I don't know if we can mention the name exactly because I know he mentions it in calls and I don't want to say it, but I think it is crazy to think about, like 27 years worth of data to go back through, and most of it, a good portion of it being digitized. There are some breaks in certain center change because of just, personality differences and people trying to practices elsewhere. And, I'll see a patient that had like 3 or 4 DEXA scans and then they went to a different center for a while. So like you kind of have some lapses, and it wasn't all into like the digital age and era. It was like hard file copies. But I mean, even then, like, it's definitely crazy to think. I mean, we have certain people that have been utilizing our services for over 2 decades now, like,
Wow.
like literally from like day one type people. And when I first got into this, I'm like, I'm a 26-year-old kid. I'm like, why is this important? Why does this matter? And then now I'm into like my early 30s. I was like, I get it. I see why this matters, and trying to speak more to, again, even people that I'm around. Like they're like, what do you know? And I'm like, I'm just a health coach. Like, you need to actually talk to this one of the doctors there. They can give you like the ins and outs. They're like, you already know so much. I was like, I know nothing compared to these guys. I'm just going after the things that really concern me: metabolism, how your glucose is looking, the basics things of the cholesterol. Then you get into the weeds with them. I'm just giving that quick glance so I can help curate like the baseline plan. Like you'd mentioned, Dr. Martin, like go in, make sure we're on the same page on what we're trying to, quote, be prescriptive about with the food, and then let the rest of the things come forward. So it's exciting times.
Well,
for sure.
I will give you a little pushback on that, because I don't think the health coaches are just a junior version of the physicians or anything. I think you provide a value that's unique that the doctors can't provide, and a skill set that we don't have. And so I think working collaboratively with the health coach is a huge value add and something that a lot of patients can't get. So I definitely wouldn't undervalue that.
No, I'll take that. I appreciate that. What it actually, like you'd mentioned, like it's never too late to go back and kind of do that thing from like that, kind of put a physician hat on. It's definitely something that now seems like it's really actually obtainable because I've had real world experience. Whereas before it was like, yeah, you're going to go put 8 years into doing something, so it's like, yes, it is like a junior role in some areas, but our areas of expertise were more about like the foods and the psychological approaches around food and how to get people to commit to things. And being health coaches like myself and Seamus have gone after, and being board certified, which a lot of people can't say that they do inside of a practice, to really bolster that. And, it's again, like you just said, having a different way of approaching it. I had a new patient like kind of break down because I don't have my own place to go to, and I feel some type of way. And it was like an internal reason why she wouldn't want to go after getting like exercise and her nutrition down right away. And I already knew the conversation she's going to have with, Dr. M, because, I know his personality type and he can be a little bit more kind of blunt and to the point. Whereas I'm over there like, hey, when you're ready, I got you with regards to these things. I need you to take care of that thing that like helps you feel complete, which was something that Seamus and I have been working on for the last like year and a half, like understanding like ready, willing, and able, what people are telling you, reading between the lines. Like, I mean, when people break down
than
with
what
you,
they're saying. Yeah.
this person was literally breaking down and having like a moment and crying, like as part of like her initial consult, which is like, again, I was like just trying to open up that space for it. So that's like a unique thing that you're definitely not getting, like you touched on earlier. If you have 15 minutes, no one's trying to get to know you, what your problems are. And I was also saying like, hey, like I'm not qualified to handle those things. And luckily she was like, I am working with a therapist and trying to like come to terms with these things. So perfect. Also like staying in my lane. I understand that, but just having that moment to do that, like you don't get that. And that was the moment where it really put like it all together. Of course, it happened that like the day before or the day after we took our test, Seamus, and I was like, okay, I guess like, yeah, like I've definitely learned a lot, but I don't know if I passed the test.
Well, hey, we'll see in about 6 weeks now at this point. So
Yeah,
I'm sure you guys did great.
Marcus, close us out here, man. Close us out here.
Yeah. All right, guys. Well, Again, we appreciate Dr. Martin giving us, a little over an hour of his time today, giving us a little bit of a deeper dive of understanding, some of those preventative measure tests in terms of understanding some cholesterol, kind of a little bit of a deep dive there, different things there, why, PCP providers are really worth their weight in gold, and why you really having established care can be really helpful. Again, it's something that I now know that I need to do as well. Granted, Dr. Victoria basically is my primary care physician. He's just not officially, but all that being said, like, it's super important, like taking, like you'd mentioned, like just putting it into put that onus on yourself. Get educated, understand those things, absorb those things, ask those questions to them, the professional. Becoming prepared, like Dr. Martin was saying, is something that he looks forward to with his patients, because they want to talk about those things and they know that they can develop the care plan around that. So again, this series has been super insightful. We have our goal is to actually get everybody in our company to come on the podcast, because they all provide something different. And let me tell you, the inner workings of what a big corporation has to do to deliver healthcare in a private manner would blow your mind. From the shipping logistics to dealing with outside pharmacies to dealing with a bunch of little things that go on behind the scenes. It's actually a really cool thing.
Licensing, all these.
Oh my God, people don't even know. Like, how hard is it? It's like, yeah, well, it's shipping things in. There's different regulations, state to state
regulations. Like, holy cow, yeah, it's crazy.
Yeah, so we're glad that we've been able to have great positions and talk shop a little bit about why you guys are so passionate and why you've been able to come into this, and what led you to us, especially you being, like you said, with us for the last 4 months. So we're excited to have you, Dr. Martin, and everybody, thank you for listening. Until next time.